Welcome to part 2 of our Body CT On-Call series. In this talk, we'll cover the luminal GI and bowel emergencies, working from the stomach down to the right iliac fossa. Let's begin. First up is perforated peptic ulcer, which usually presents with sudden epigastric pain and a rigid abdomen. On a portal venous CT, reviewed on lung and wide windows, you'll see free intraperitoneal gas, perihepatic and along the falciform, concentrated up near the duodenal bulb, with a focal wall defect and periduodenal stranding localizing the site. The main complications are generalized peritonitis, with free gas and fluid across all compartments, and retroperitoneal perforation, where the gas tracks backwards rather than forwards and is easily missed. On your report, describe the free gas and the focal wall defect, giving it site, then ladder up through any walled-off collection to generalized peritonitis. This needs urgent surgical review for repair. Next up is the dreaded small bowel obstruction, which usually presents with colicky pain, distension, and vomiting, often in the context of a hernia or previous surgery. On a portal venous CT, you'll see dilated small bowel over 3 centimeters, running to an abrupt transition point, with collapsed bowel beyond and a feces sign confirming the level. Watch out for a closed-loop obstruction, as it carries a real risk of strangulation. The main complications are ischemia, with reduced wall enhancement and mesenteric edema, and pneumatosis, or portal venous gas, which means the bowel has infarcted. The differential is ileus, which is diffusely dilated bowel with no transition point. On your report, give the caliber and the transition point with its region, then flag any closed-loop configuration or ischemia for urgent surgery. Large bowel obstruction is next, usually presenting with gross distension and absolute constipation. On a portal venous CT with coronal reformats, you'll see dilatation over 6 centimeters, cecum over 9, down to a transition point. The cause can be a simple volvulus or an apple core stricture signifying carcinoma. Look at the small bowel too, because if it's collapsed while the cecum distends, the ileocecal valve is competent and you've got a closed loop with a rising perforation risk. The main complications are cecal perforation with a tense cecum over 9 centimeters and ischemia. The differential is pseudo-obstruction, dilatation with no mechanical transition. On your report, give the caliber and transition point, then the cause. Flag a cecum over 9 centimeters or pneumatosis. This needs urgent surgical review. That brings us to mesenteric ischemia, which gives pain out of proportion to an unremarkable early exam, classically in AF or a low flow state. It needs a CT angiogram, arterial and venous. The key finding is reduced wall enhancement in a vascular territory with a sharp cutoff, with an arterial or venous filling defect as the cause. The main complications are perforation from non-viable bowel and peritonitis. The most feared is transmural infarction, which is the triad of pneumatosis, portomesenteric gas, and pneumoperitoneum. The differential is inflammatory wall change. The trick is the direction of enhancement. Colitis hyperenhances, whilst ischemia hypoenhances in a vascular territory. On your report, give the territory, the cutoff, and the vessel. Then note wall thinning, pneumatosis, and portomesenteric gas. This is time critical and needs urgent surgical review. Next up is acute colitis, which usually presents with diarrhea, pain, and fever. On a portal venous CT through the whole colon, you'll see mural thickening with hyperenhancement, a submucosal edema target sign, and pericolonic stranding with the comb sign. The main complications are toxic megacolon, perforation, and ischemia with pneumatosis. Here's a table to recap the main types of colitis with the differences highlighted. Pseudomembranous from C. difficile gives the thickest walls with the accordion sign post-antibiotics. Typhlitis sits in the cecum in a neutropenic patient. Ulcerative colitis runs continuously from the rectum, whilst Crohn's is skip lesions and terminal ileum with fistulae. And ischemic colitis takes the watershed zones with patent vessels, often self-limiting. Radiation colitis didn't feature in the table, and it's confined to the radiation field, so the clinical context is a big clue. And remember, colitis is a diffuse process, whereas entities like diverticulitis are more focal and asymmetric. On your report, describe the mural thickening with pericolonic stranding, the distribution, and a favored cause. Flag toxic megacolon, perforation, or pneumatosis, and refer urgently where present. Speaking of acute diverticulitis, this usually presents with left iliac fossa pain and fever in an older patient. On a portal venous CT, you'll see diverticulosis with segmental wall thickening of a long segment and pericolonic stranding disproportionate to the wall change. The main complications are perforation and a drainable pericolonic abscess worth measuring. Also look for a colovesical fistula, where gas in the bladder is the giveaway, and a stricture, which raises the suspicion of malignancy. The differentials here are the two fat infarction mimics. Epiploic appendicitis sits on the left, adjacent to the sigmoid, as a small fat lesion with a hyperdense rim. Omental infarction sits on the right, a larger ovoid fatty mass with no bowel wall thickening. On your report, describe the diverticulosis, segmental thickening and stranding, laddering through perforation, abscess, and fistula. Refer for surgical review where complicated. Last but not least, acute appendicitis. The classic story is right iliac fossa pain with a low-grade fever. On CT, you'll see a dilated appendix over 6 mm, fluid-filled and blind ending, with wall thickening and periappendiceal stranding. An appendicolith raises the perforation risk and is worth flagging. The main complications are perforation, an abscess or phlegmon, and a small bowel obstruction. Also look for pylophlebitis, which is portal venous thrombosis from spreading infection, rare and easily missed. Take care not to mistake this for other right-sided inflammation with a normal appendix, mesenteric adenitis or terminal ileitis, giving inflamed nodes or ileum, and cecal diverticulitis. On your report, give the caliber, wall thickening, and stranding. Then note the appendicolith, perforation, abscess, and pylophlebitis. Refer for surgical review. And that closes part 2. We'll pick up the abdominal and pelvic trauma cases in the next talk.